Good morning, everyone. Livugenjani, Mangwanani. It's truly an honor to be here today and to talk to you about adolescent HIV, a topic that I'm very passionate about and a patient population that I have the privilege to work with. As all of you know, there are about 1.8 to 2.1 million adolescents infected with HIV, and the vast majority of those adolescents are here in sub-Saharan Africa. There are three main groups of adolescents infected with HIV. Two groups are perinatally infected adolescents. The first are kids who come into care very early on and access treatment and typically do quite well. They have very different clinical and psychosocial issues to the children who are diagnosed later in life, particularly in late childhood and early adolescence. And the third group is made up of adolescents who are infected through sexual transmission as adolescents. We've made significant strides in perinatal HIV infection and in reducing the number of pediatric infections. However, a significant cascade exists. In this study conducted in communities in Zimbabwe, they found that among HIV-infected children of HIV-infected pregnant women, 19% of those who were positive, only 19% were linked to care and initiated on infant ART. The remaining 80% are the kids that we see in our pediatric hospitals or the kids who present to care late. So although we've achieved great strides in the PMTCT program, there are still significant gaps, and those gaps are the kids who become adolescents in our clinics. We know that median survival in the absence of therapy for children is very poor. However, a small subset of children, about 13%, survive into adolescence in the absence of treatment. In a demographic survey conducted in Manicaland province in Zimbabwe, between 1.6 and 2.5% of children and adolescents were HIV infected, and a large percentage of those children are unaware of their HIV status. We as healthcare providers provide several barriers to adolescent HIV testing. In work done by Rashida Farran's group in Harare, working in primary healthcare clinics within the city of Harare, they identified 2,800 children and adolescents between the ages of 6 and 16 years who were eligible for provider-initiated testing. Only 76% of those children were offered testing, and only 54% received testing. When they asked healthcare workers why they did not offer testing, there were several barriers identified. Healthcare workers perceived that some of the guardians were unsuitable to provide consent for the adolescents. They misinterpreted the law and felt that they needed to provide both HIV testing to the child as well as the guardian, leading to another barrier to testing, and perceived increased workload primarily associated with pre- and post-test counseling of children compared with adults. So as a consequence, asymptomatic children, male children, and those with younger guardians were less likely to be tested, and male guardians were less likely to consent to testing of children. They found that 5% of those children were HIV infected, and unfortunately the majority of those kids are kids who interface with the healthcare system. Most of them had vertical infection. More than half had a parent or a sibling who was HIV positive and on ART. As providers, it is critical that we ensure that we test the children of all of our patients and the siblings of our pediatric patients as well. And most of those children had attended a primary healthcare clinic at least once in the past 6 months. If we do not test these children, many of them present to care late with very advanced disease. The third group is adolescents who are acquiring infections sexually later on in life. Data from here in South Africa shows that adolescent girls are at highest risk of infection. In sub-Saharan Africa, 7 out of the 10 new infections in 15 to 19-year-olds are occurring among adolescent girls. In work done here by the Caprisa team a few years ago, looking at 9th and 10th graders in rural schools in KwaZulu-Natal, they saw a sharp increase in the prevalence of HIV infection among adolescents, with 20-year-olds, 1 in 4 20-year-old female adolescents testing HIV positive. They identified many biological and socio-behavioral factors associated with this. Adolescent girls were more likely to have older partners who were 4 or more years older than they were. HSV2 seroprevalence was higher among adolescent girls, and social factors that made adolescents vulnerable to transactional sex, sex with older partners, placing them at risk, were also evident. So what are the treatment outcomes among HIV-infected adolescents? Unfortunately, we're not doing as well with adolescents in care. This is data from 2012, and AIDS was the #1 leading cause of adolescent deaths in Africa, and the #2 cause globally. The greatest burden of morbidity and mortality is among perinatally infected adolescents. In our healthcare systems, we're failing to retain those adolescents in care. This is data from a large public program in Zimbabwe, and we find very low long-term retention rates, particularly among older adolescents as well as infants. When we looked at virologic failure and drug resistance, we found that between 35 and 40% of our adolescents were not virologically suppressed. This was significantly higher than suppression rates among adults in the same clinic. And yesterday we saw a presentation of similar data from here in South Africa. In many low-income, low-resourced settings, there is very limited access to viral load monitoring, and monitoring is largely clinical and immunologically based. We sequenced viral isolates from some of the children and adolescents failing therapy, and 2 key patterns emerged. About 1/3 of the adolescents had no clinically significant mutations. So many of these kids had essentially stopped taking their drugs, and we could put them back on the current regimens they're on and presumably achieve virologic suppression with appropriate adherence support. However, the majority of the kids did have a significant drug resistance, and most had 2 or more clinically significant mutations resulting to resistance to multiple classes of drugs. I think drug resistance among adolescents is going to become a major clinical factor, particularly for those of us providing care to adolescents in programs where we have limited therapeutic options. The last thing I want to touch about are the chronic clinical consequences of HIV infection among adolescents, and this was beautifully reviewed by Elizabeth Lowenthal. All of us who provide care to adolescents know that there is a significant amount of stunting among our adolescents in care. There's a lot of chronic skin disease, both plain or warts related to HPV, molluscum, drug-related toxicities, chronic lung disease, neurocognitive developmental issues, as well as deformative conditions such as early strokes or seronegative arthritis. In addition to the clinical manifestations that are evident, there's a significant amount of mental health issues among our adolescents. In a study done by Shamiso Jombo and Kamia Kidia in our group, looking at depression among adolescents, they found very high rates of moderate to severe depression, ranging between 15 to 30%, and found a strong association between age of diagnosis or disclosure and severe depression. The earlier we are able to test the kids and bring them into care, the better that they do in terms of mental health and depression and stigma. We also identified very high rates of internalized and perceived stigma among our adolescents and young adults. We then talked to our adolescents and heard about their experience, and some of our kids are maturing from childhood to adolescence under our care and transitioning through a number of psychosocial and behavioral issues. I'll just read one quote from an adolescent within our cohort who said, "When I was young, I just accepted it because I did not know what it means. But when I was in Form 1 or 8th grade, I started wondering what had happened. Because sometimes when I was at school during guidance counseling lectures, some people would say negative things about people living with HIV. They were not aware that I was also positive, but they actually thought other people were positive, not me. Like this other slim boy, so they thought he was a sick person. They did not know that I was positive, so I decided not to tell them, and I thought it was better that way. So when I was in Form 1, I would talk like a person who was negative, but I'd say encouraging words such as it's all about accepting that you were born like that." The children and adolescents and young adults that we take care of deal with a myriad of clinical and psychosocial issues that I know at that age I could never have been able to deal with. So we are asking a lot from our adolescents, and in addition to all the clinical, psychosocial, socioeconomic issues that they're dealing with, we're asking them to take drugs every single day. I cannot take drugs every single day. And so our 16-year-olds tell us, I would skip here and there. I would then start to adhere again after I fell sick. So I think the challenge is for us as healthcare providers, clinicians, and scientists to develop new solutions for our adolescents living with HIV, be they biomedical solutions such as depot-infused drug formulations, or a cure or therapeutic vaccination, as well as system-wide improvements that enable us to provide better care to our adolescents and ensure that they are retained in clinical care. So to summarize, we've made significant improvements in pediatric HIV infection and reduced the number of kids acquiring HIV infection. However, there remains a significant cascade, and that cascade translates into many adolescents entering into care late and becoming patients within our adolescent clinics. We need to improve our care systems, optimize retention and care, increase access to virologic monitoring, and improve outcomes on ART for our adolescents so that we can reach 90% virologic suppression rates. And we desperately need to find evidence-based solutions that will enable us to provide comprehensive care that includes clinical care, mental health care and support, and psychosocial support for adolescents living with HIV. I thank you for your attention and thank the numerous people who work with me on this and our numerous funders as well. Thank you.